Hopefully you can.
Yes, we can.
So thank you for the invitation to speak. I'll speak for about 25 minutes on this topic of Richter transformation. I think we all recognise that this is a very distinct, uncommon but difficult scenario that we sometimes face, and I'll run you through some of the current thinking, some of the clinical workup, and also some of the investigational sort of data in this space that's helping influence our practice. Here are my disclosures. So Richter transformation was first described nearly 100 years ago now as an American pathologist who described a patient with a low-grade lymphoma developing a low-grade sort of indolent disease at that time, then later found to be CLL, basically developing a life-threatening syndrome with rapidly enlarging lymphadenopathy. But it wasn't until the 1960s where this term Richter transformation was actually formally coined based on more cases described. And then, of course, this has become a well-described disease entity now. Most of the transformations are to a activated B-cell type or non-GC type diffuse large B-cell lymphoma, but of course you can rarely transform to Hodgkin type Richters and also very rare other entities as well. The patients we should suspect Richters in are patients with CLL who develop disproportionate weight loss, rapidly enlarging, asymmetrically enlarging lymphadenopathy, extranodal disease, or a rapidly rising LDH or a new high calcium or necrosis on a CT scan. A combination of those factors make you concerned. Of course, the disease is fundamentally a histological diagnosis, and so it's critical to get tissue from FDG avid masses wherever possible. If you do confirm the diagnosis, most patients have clonally related disease to their underlying CLL. And unfortunately, if you look into the literature, the median overall survival is somewhere just under a year. Now, the rates of transformation have been variably reported, but probably represent about 2 to 3% of our patients that we see with CLL. Now, of course, a number of interesting and important questions that still exist are around whether you can change the natural history of the disease by offering non-chemotherapy based treatment. And there's some suggestion from recent data, I've just put an ASH abstract up from last year, that in the novel era, there may be a reduced rate of transformation, although it has to be said in studies like, for example, the Murano trial, there was no difference between the rates of transformation following BR or venetoclax rituximab, and actually in this series both groups still had prior historical chemotherapy. So we don't have a lot of data on, for example, novel approaches from diagnosis and what that does to the risk of transformation. So it's still an open question. So what do you do around the diagnostic workup? Well, the first thing is just a few words about PET scans. So PET scans can be useful in patients with Richter transformation for a couple of reasons. Firstly, if you've got somebody who don't think has Richters and you do a scan and for whatever reason, and their SUV is generally less than 5, although in some series less than 10, but generally speaking less than 5, then that actually has a very high negative predictive value for Richters. And so you probably don't need to go on then and look for biopsy sites and so forth. You can probably manage patients as if they have CLL, SLL. So it can be useful if the SUV max is low. It can also be valuable, of course, if you have a really dominant site or a disproportionately avid mass or area, because it can help target biopsy. So those fundamentally are the two key reasons to do a PET scan. I've just listed some of the recent references that have helped define the use of PET. There is really relatively limited data with patients post, for example, BCL2 inhibitors or BTK inhibitors, and I think some of that data still needs to be sort of more fully worked out. But in essence, those are the sort of rules of really where PET is valuable in in people who you're concerned may have Richters. And the other really important thing to mention is the workup of patients and looking at the diagnostic material. And just a reminder that this really is a histological diagnosis. And ideally, you need specialist hematopathology review. We did a UK-based study a few years ago and actually got 2 independent and blinded hematopathologists to look at the biopsy tissue, and actually they only felt independently that about 80% of the patients who were initially enrolled in the trial actually ultimately had Richter transformation as opposed to accelerated CLL or some other issue. So I think it's really important to get expert eyes on the biopsies for these patients, because the histological WHO defined definition of Richters is different to, for example, just accelerated CLL, which we sometimes see in these patients. The other 2 important factors to at least consider testing for, if available, are the clonal relationship to the underlying CLL. Certainly those patients with clonally unrelated disease probably do better, although it's still recognized that the evidence base for treating patients differently is limited. And the other important factor, and this has been a consistent finding, is that patients with a TP53 deletion or mutation do substantially worse from a progression-free survival point of view compared to those patients that don't have a TP53 disruption. You can see here the differences in this series from over a decade ago now. The other key thing is actually the context in which the transformation occurs. So here's some data from the Mayo Clinic and also some data from ASH last year. So on the left-hand side, you can see here, this is overall survival according to prior CLL treatment status. And so if you have had prior treatment, you're the red line. And if you've never had prior treatment for CLL, you're the black line. And so that really is a stark difference. And it makes biological sense, of course, but just a reminder that actually your survival is very much influenced by your historical CLL disease course. And this is dividing patients further into whether they've had 1 prior CLL treatment or more than 1. And again, you can see quite a substantial difference here. Something similar has been shown from data at ASH. These are patients in the novel agent era, where to look to see whether they've had prior treatment for the CLL, and then also transformation. Concurrent diagnosis or a prior diagnosis but no prior treatment. You can see here this substantial difference again being seen. So the context of diagnosis is really important. Okay, so if you make the diagnosis, what are the clinical challenges here? Well, this schema hopefully just describes some of them. I'm just going to run through some quickly. So the first thing to say is you often have a patient deteriorating quite quickly in front of you. Clinically, they can develop a rapidly deteriorating performance status, can have quite bulky disease. The kinetics of this disease is generally quick. And so you don't have a lot of time to play with if you think somebody's got transformation. Of course, CLL is a disease of older people, and so often comorbidities and other organ dysfunctions can sort of play into the challenge. Many patients historically may have had chemotherapy. The genetics of the disease I'm not going to talk about in great detail, but often these are the sort of findings you see. CDK and 2A mutations, TP53 mutations, and MYC mutations are really quite common and often lead to chemo resistance and also proliferation. So those are the challenges there. And of course, one of the key things also is the delivery of treatment is challenging sometimes because the CLL is often quite quite sort of commonly infiltrating the marrow, and that means, for example, delivering immunochemotherapy to standard dose on time is actually challenging because of this. So giving, for example, 6 cycles of R-CHOP chemotherapy in this setting is sometimes quite a lot more difficult than if you're giving it, for example, in just a de novo DLBCL patient. And one of the challenges, and I'll talk more about this, is the relative lack of clinical trials and the fact that there haven't been any pivotal or registrational studies per se in Richter's alone. Okay, so how do we treat Richter's? This is a historical slide of attempts made over the last 20 years or so to analyze different chemotherapy-based regimes, and I've just listed some of the sort of most common regimes here. You can see here sort of anthracycline-based treatments, platinum-based treatments, and fludarabine-based treatments as well. And a couple of things just to say, they are quite toxic. You see quite a lot of cytopenias. You can see here the treatment-related mortality ranging a bit here between a couple of percent, but right the way up to nearly 20% with some of the more intensive treatments. And then sadly, the median survival in these series is short, as I mentioned, between a few months up to sort of a year or so. And the other thing to say importantly is actually these are very modest sized clinical studies, anywhere between 7 patients at the bottom there up to a maximum of 35 here. So really the clinical trials that we've seen historically with chemotherapy have been fairly limited. This is also reflected by one of our UK studies that we performed. So we published this now 8 years ago. 37 evaluable patients were enrolled, and CHOP was given alongside ofatumumab, so sort of historical CD20 antibody then, and ofatumumab maintenance was also added in here. And you can see, sadly, this didn't really improve on historical outcomes. Median progression-free survival only 6 months, with a median overall survival again at a year. And there were no particular subgroups that really benefited from a response point of view. One of the key things here is you actually lose responses on therapy. So the overall response rate was 65% after 4 cycles, but by the end of 6 cycles, that dropped to 44%. So 20% of those responders were actually losing their response on treatment. So clearly one of the key issues here is just the innate chemo resistance that this disorder unfortunately leads to. What about dose-adjusted EPOCH-R? We know there's some data in double-hit lymphoma, in patients with a MYC rearrangement. Can you improve on outcomes with Richter's? Well, the answer is probably not. Here's some data from the US demonstrating short, median progression-free survival, and also a very sobering statistic of 30% of patients actually dying without disease progression or response. So this is really demonstrating some of the toxicities that you see with dose-adjusted EPOCH-R, and it's certainly not my routine practice to deliver this in patients with Richter's. And one of the key things here is, if you do get patients into a remission, should you offer a stem cell transplant to patients? This is probably the best data that exists. This is data from the US, from the CMBTR registry, looking at patients with autologous transplant and allogeneic transplant. And of course, as you might expect, you get more relapses with auto than you do with allo, but the non-relapse mortality is higher with allogeneic stem cell transplant. So actually, the 3-year progression-free survival is an overall survival are pretty similar. But allo transplant obviously has a better ability to target underlying high-risk CLL and probably leads to the higher chance of cure. And so it's my preference broadly to perform allo stem cell transplants in this setting. You can see here that your remission status going into transplantation, allo transplant, is really important. So the deeper remission you're in, the more likely you are to survive longer. And if you have really genuinely resistant disease, I'm not personally convinced an allo transplant gives people great benefit. Now, of course, one of the issues here is actually the broad applicability of stem cell transplants, really limited by the lack of durable disease control that you find in people in first remission. So, of course, you ideally need patients' disease to be under good control while an allo transplant sort of works, and you get graft versus lymphoma effect and graft versus CLL effect. And one of the issues here is you just don't get that time often because patients relapse very quickly often. So how do I treat patients with Richter's now? Well, this manuscript from the JCO last year that I co-authored with some Australian colleagues I think really highlights how I manage patients. So obviously looking for clinical trials at any time point during the disease entity, I think is clearly critical. But outside of a clinical trial, I would say a sort of inadequate but a sort of recognized standard of care is still R-CHOP chemotherapy. And then I think about allo stem cell transplant in first remission if a patient has any one of these features, so a TP53 disruption, clonally related disease, or a prior CLL therapy. All of those are sort of represent higher risk groups. If they don't have any of these features and they obtain a remission, then I think it is reasonable to observe those patients. But of course, those represent the real minority of patients. The relapse refractory pathway is listed here. I won't go through this in detail. Of course, clinical trials are critical. Anti-CAR T cell therapy does look active. I'll show you some data here. And there have been some interesting molecules coming through in clinical studies, which I'll talk about shortly. And of course, if you're fortunate enough to get somebody back into remission in the relapse refractory setting, you should also consider allo transplant. But the same issues certainly exist with durability of disease control in that setting. So a look to the future. Have we seen anything recently? Have we got novel agents which may change the treatment pathway and the development in Richter's? So the next couple of slides, really a summary side of the literature looking at different targets and different agents that have been at least studied and are in a degree of development. And what you can see here is a list of treatment options, covalent and non-covalent BTK inhibitors as monotherapy here in green. I'll talk a bit more about pirtobrutinib here because the data is really sort of standout data in terms of at least patient number. One of the issues here, though you do get reasonable responses and clearly BTK inhibitors are easy to deliver tablet form treatment, one of the issues here is that the duration of response again is not great as monotherapy. What about novel combinations? Well, we have seen interesting data with BTK inhibitors and PD-1 inhibitors. And again, I'll talk a little bit more about the RT1 study because that has demonstrated some quite interesting results with, again, some durable responses seen in some patients. BCL2 based treatment, so venetoclax alongside chemotherapy does look active. Matt Davids from Boston has done a lot of work here looking at responses in patients who've received venetoclax plus either dose-adjusted EPOCH or then more recently the protocol was amended to include R-CHOP. And you can see here CR rates really pretty good in the range of sort of 50 to 60%. But median PFS still sort of somewhere between about 7 to 10 months. So perhaps a little bit better, but not game-changing data. And then we've seen some interesting series of bispecific antibodies. So you can see here two molecules that are licensed in DLBCL. You can see here demonstrating really quite good single agent activity with CR rates of 45 to 50%. Of course, very small patient numbers, but still interesting. And mosunetuzumab does look active as well, but the CR rates look quite a lot lower compared to glofitamab and epcoritamab. So I mentioned I'd talk about pirtobrutinib in a little bit more detail. So this is a highly selective non-covalent reversible BTK inhibitor. It's been studied in a lot of patients now in the Bruin trials. It's very selective. And one of the advantages here compared to other BTK inhibitors is you get coverage across over the IC90 for BTK from a pharmacokinetic point of view across the 24-hour period. So in theory, that may be more important for diseases where there's substantial proliferation and cell turnover, such as Richter's. Here's the data with Richter's, 75 patients, most of which are previously treated. And you can see here the overall response rate over 50%, with actually tumor reduction in most patients, at least initially. So certainly demonstrating single agent substantial activity in this disease. But one of the issues here is the relapses occur earlier. So median progression-free survival in this whole cohort is only about 3.5 months. But certainly it does suggest real activity, and this agent is very well tolerated and could be combined in clinical trials. I mentioned the RT1 study, so this is the PD-1 inhibitor tislelizumab plus zanubrutinib, so second generation covalent BTK inhibitor in Richter's. 59 patients were enrolled. They had a slightly unusual rule, which patients who dropped off early were not considered in the efficacy evaluable patient population. So do bear that in mind if you read the manuscript. And you can see here the response rate when those patients were removed was 58%. And actually, this PFS curve, although encouraging with some durable remissions, did exclude those 11 patients that progressed early. So it suggests certainly here that there are some patients who get very durable responses, and one of the key things is trying to work out sort of who that group is. This looks like a well-tolerated combination. And then in the relapsed refractory setting, I did say I'd talk about CAR T cell briefly. So anti-CD19 CAR T is clearly a highly active treatment in diffuse large B-cell lymphoma, and Richter's hasn't been studied to the same degree. Of course, T-cell function in CLL is a particular issue, and certainly has to some degree limited the development of T-cell engaging therapies in CLL and Richter's. His data on 69 patients, they were heavily pre-treated. Nearly all had received a prior BTK inhibitor or BCL2 inhibitor, and a median of 4 prior lines overall, 2 for the CLL and 2 for the Richter's. Most patients required bridging. So these were a high-risk group of patients. Now you can see here that there are some durable remissions. This is going out to sort of 3 years follow-up here. Some patients, maybe 20-25% of patients in a long-term remission, but very few patients here sort of at risk from a Kaplan-Meier curve point of view. And this is a fairly toxic therapy in this setting, with a non-relapse mortality of 13% and quite a lot of infectious complications, and also cytokine release syndrome and ICANS. So it's not necessarily straightforward to deliver, but I think there are a proportion of patients that get sort of durable responses. And if you obtain a CR, you do pretty well. If you don't, then you relapse very, very quickly. So that's some of the data that exists at the moment. Now, of course, in theory, there's lots of rational combinations that you can look at from clinical trials. And this is just a summary of some of the ongoing clinical studies that we've seen. There's a lot of detail on this slide. I just want to highlight a couple of things. So firstly, the bispecific antibodies are being studied in more detail. So we should see more, hopefully some more data there in the future. This is a study which I think has some real potential. So this is a randomized clinical trial of CHOP-based therapy, so R-CHOP or R-mini-CHOP versus pirtobrutinib plus epcoritamab in patients who previously had untreated Richter's. That's a randomized study, 112 patients run by the German CLL study group. So do look out for the results of that in the future. It will take quite a while to recruit to that study, clearly, but of real interest. And then I just want to highlight a couple of other studies. So in the UK, we have the ongoing trial of R-CHOP versus R-CHOP plus acalabrutinib. It's called the STELLA trial. It's recruited now over 40 of the 60 patients. So we will hopefully see results of that in the relatively near future. And then this is another interesting study where glofitamab is being added into immunochemotherapy in a 40-patient single-arm study. So again, that's an area of real interest. And of course, at the moment, I think we're at a bit of a crossroads where we don't know whether we should be using chemotherapy as our backbone or whether we should be using sort of novel approaches. And I think that really is still very much to be debated. So this is my last slide. So clearly, the context of the outcomes for Richter's depend very much on the context of the disease. So lines of therapy, concurrent diagnosis, genetics, and clonality, I think, are key considerations. One of the challenges to recognize what a standard of care is. Is there one? I mean, R-CHOP or R-mini-CHOP is used very much as a control arm in randomized trials. So that's probably a standard of care. It's not a particularly adequate one, but I think it's what exists at the moment. I think you should consider allotransplant in first remission for suitable patients. And we've seen lots of development across hemato-oncology, and that's starting to impact the management of Richter's. Many of these agents are well tolerated. They lend themselves to combination studies. But of course, none of these studies have been pivotal studies designed at licensing and reimbursement. And sadly, we don't have any sort of active therapies that we have outside of our standard of care treatments that are readily accessible. And hopefully that will change in the future. And of course, not all these patients will respond to these therapies. You can see response rates that I've demonstrated to you between 30 and 50%. And so it'll become increasingly important to understand who responds to non-covalent BTK inhibitors, bispecific antibodies, PD-1 inhibitors, etc., because there's a lot of efficacy as monotherapy, but the response rates are fairly modest, and so we need to sort of ensure we understand biologically who is responding to these treatments and who isn't. So that's a brief tour of Richter's transformation. I hope that was of interest. I'll stop sharing my slides now, and I'm happy to take any questions.